So Geoff, many of you will know Geoff. He is the Chief Executive of Nesta, the National Endowment for Science, Technology and the Arts, and he was formerly Chief of the Young Foundation and also Tony Blair's Head of Strategy and Founder Director of Demos, so he really does have a long, distinguished history. Nesta, the organisation he's with at the moment, the mission is to make the UK more innovative, which is quite what we need at the moment. Perhaps a few basic questions to start off with, Geoff. You've travelled around a lot around the globe, around the public sector, around the private sector as well. On a scale of 1 to 10, how innovative do you think the NHS is relative to other parts of the public sector and also relative to other health systems around the globe?
I think it's very hard in principle to answer your question because the NHS is an odd mixture of, more than any other public service, a foundation in science and applied science, which means there is a constant sort of flow of new knowledge and of fairly rigorous new knowledge compared to policing or teaching or transport planning even. But in other respects, it's probably less innovative because it's got very strong institutions, and strong institutions tend to be quite good at stopping threatening innovation. One of the things I was going to say is, although I don't have, unlike the Secretary of State, any slides, is there's fairly extraordinary data now across the OECD which roughly correlates how much a country spends as a share of GDP on health and how much your adults die. And those correlate positively. They should correlate negatively. And also, the more you increase your spending on health, the worse you do in improving adult mortality rates. Now, those are pretty dramatic symptoms of health systems right across the Western world which are facing an acute productivity crisis, which you'd have thought would be leading to very strong pressures for innovation, but I don't think it is yet. And the other statistic, which again many of you will be familiar with, is the mismatch between what makes people die, and what we know from medical science, and where research goes. The usually cited figure is that only 0.5% of medical research goes on the behavioural, social and other factors which appear to cause at least 60% of mortality. So we have a massive mismatch between our innovation system and where you're most likely to get the gains. Where you see that most acutely, and a big issue for the UK, is the pharmaceutical industry, which has in the last 2 decades seen steady declines in its productivity of innovation. Ever fewer useful drugs coming out of an industry, ever more money going in. And a global crisis of that whole industry in terms of its contribution to this field. I think a slightly lesser crisis is assistive technologies. Again, enormous amounts spent, but pretty disappointing results all over the world if you measure rigorously in terms of impact on QALYs or something like that. And I think one of the real problems of the reforms of the last year or two is they've almost taken our eyes off the fundamental questions, and a real crisis of our innovation system. Very expensive, very impressive in some respects, but not really delivering the goods.
When you talked to several members of the private sector about what life is like in trying to enter the market in Britain as an innovating, for example, private sector provider, what you hear from, I suppose it's expected, is that there's a lot of red tape in Britain compared to other European countries when it comes to entering the market. Red tape from all sorts of regulations that simply don't exist elsewhere to the same extent. Do you have any observations on this, having been around?
I'm not sure about that, and others will know better. I mean, many European health systems are every bit as much bureaucratised and regulated as the UK, and arguably pharmacists are more regulated in many other countries than here. Clearly, we want regulation to protect the patient interest, safety, etc. But one of the things I think, again, you'll see when Devi talks, is that key to the way he's managed to get the big improvements in both clinical outcomes and sort of productivity in his hospital is by changing quite a lot of the rules, which are very fixed here in the UK, and I think in most of Europe, and in particular demarcations between both different doctors, between doctors and nurses, between nurses and ancillary staff, they have looked at in a largely fresh way in terms of what works best. I was asking just before the session, I was trying to remember a figure, someone in this room will know the correct figure on, the number of proposals there have been in the last 10 or 20 years to change demarcations in British hospitals, which have been blocked by the Royal Colleges, BMA and others. My memory is that 95% of all proposals have essentially been blocked. And that makes it very, very hard to implement the sort of things he's doing in India. That is definitely red tape and regulation, which doesn't appear to be actually serving the public interest, the patient interest, is, I suspect, and so was an ill-conceived attempt to protect professional interests, which probably don't need protecting anyway. What we lack, I think, are sufficiently sort of serious mechanisms for forensically going through regulations one by one and asking which ones actually are any more fit for purpose. And I'm not quite sure who is doing that now in the NHS. There have been attempts to do it in other parts of government recently. It needs a lot of political will to make it happen. And again, that's one of those things where the reform process has probably diverted managerial and political energies from where they could have most impact.
Yes, I mean, I noticed those of you who have read the Chief Executive's review of innovation quite closely, that really wasn't part of the result that came forward in that report, you know, to cut some of the red tape of the type that you're talking about, or at least review it all. And I think that's probably quite a, particularly, I think staff contracts would be one of them, would be one of those things in case. Can I just turn to something else? You were talking last year about the big society when you were here on this stage and about people-powered pilots. And you've recently published the top 50 innovators, which I was very interested to look at on your website a couple of weeks ago. But I was reading an unpublished study, actually, last week, which showed how if you use people, not just to craft innovation, but also with respect to choice, a lot of a study that I was reading showed that patients were not exercising choice, even when the local hospital was undergoing a severe investigation from the CQC. That CQC effect lasted only a couple of months, and then after that, patients sort of chose to the same extent as they had before. What do you, I mean, thinking about the bill for a second, choice, to what extent in people-poweredness is choice a major factor? And should we be pressing that button much harder than we are at the moment?
Well, the work we're doing is mainly with primary care and with GP commissioning clusters and others around the country who are wanting to develop more effective services in partnership with their patients. Now, choice is not actually the thing which comes up really strongly from that. It's more often patients with long-term conditions wanting to work with activist GPs to change the mix of what is being prescribed. And the frustration from the GPs is not so much that we don't have a functioning sort of consumerist market for hospitals, which is where one choice language takes you, but more they don't have sort of on their desk from the NHS the clear menu of things they could be prescribing, some of them clinical, and so it's classic GP prescriptions, but they want also to be prescribing exercise, social supports of all sorts, which they know from their own experience are likely to be as effective, if not more effective, than some of the formal prescriptions, but they don't have the structured menus of choices for them. They don't have the strong evidence base on those other things. They've got very strong evidence on many of the medical prescriptions. And that's where I think there is an exciting space for experiment and innovation, much of which won't probably work, others will work, which, as I say, is different from, I think, the argument of a few years ago, which was all about how do we create something a bit more like the high street, sort of the choice between supermarkets or, dare I say, banks. We've also just funded, about 2 weeks ago, we're running quite a large fund called on innovations in giving of money, giving of time, and also sharing of time. And quite a proportion of the applications we got had a health element in them, and some of them we supported have. So, for example, one in the south of England on care, trying to encourage people to earn care credits, which they can then cash in 5 or 10 years later, which happens in variants in Japan. Others about creating circles of support around vulnerable older people, mixing and aligning the work of the GP, social worker, but also friends and family. Lots of that kind of essentially social innovation, but where there's good reasons intuitively, and I imagine everyone in this room will know this, that often those will achieve better health outcomes than more sort of classic actions, but we simply don't have a sufficiently strong evidence base. And one of the messages of nearly all of these, and this is I think a key thing, and again we'll see what Dr. Shetty says, nearly all of these are using cheap technologies. They're using smartphones, iPads, broadband. Almost none of them are using the very expensive, I think often very over-engineered telecare, telemedicine models, which, as I said, I think have largely disappointed in terms of results, and in a period of austerity don't look anything like as appealing as they did. We've almost reached a conclusion that any technology-based model, particularly for helping people stay at home and out of hospital, if it's expensive, is probably wrong, because it's not making enough of what are now ubiquitous, very cheap technologies. And this is a painful message for, I know, a lot of the industries who have a vested interest in selling rather expensive, over-engineered technologies. But it's key if we're going to be focused on outcomes and productivity.
Yes, in fact, just to comment on that, we've just evaluated the whole system demonstrator project, and we found that there were very disappointing results with respect to impact on emergency admissions, which is, will be published shortly. Just finally, before I ask, to see if there are any questions on this particular aspect, there are people-powered sort of innovations, as you were describing, but also there are, over 1 million staff in the National Health Service, and we've been tracking quite a few innovations to try to help prevent costly hospital admissions. And I have to say, everything we've evaluated so far has been popular, but hasn't yet produced the goods with respect to reductions of hospital admissions. And we don't know why this is, to the point where we almost feel we better stop doing these evaluations. But everything we've looked at has not worked with respect to these cost savings, a bit like you're saying about global telehealth, telecare. And we're quite mystified as to why this might be, because intuitively these things should work. Intuitively it should make sense. If you put more effort into prevention, then downstream care will reduce. But that's not what we're finding, and it's not also what's been particularly found the other side of the Atlantic either. So I'm mystified as to what could be the issue here. Is it the design of the intervention? Is it the motivation to keep the innovation at full strength over the period necessary? What is it exactly?
I've got a hunch what the answer is, but obviously I can't prove it. And it's very useful that you are doing this work, because it does challenge what might be some expectations. And the analogy I would use is the iPod, which may not be an obvious analogy. Most of you probably have something like an iPod. Most people, when they look at an iPod, think this was a brilliant innovation by Steve Jobs or some designers. If you actually look at what the iPod consists of, it's an assemblage of lots of different ideas which came from other people. MP3 technology from Germany, the Fraunhofer Institute, Napster, innovations on music listings, Foxconn's manufacturing methods, and a whole series of MP3 players which were put on the market and failed before Apple came along. All they did essentially was bring together, assemble a whole series of elements which had over time been improved and tested into something which was really simple and useful. And there's a general point here which I think is also true of Narayana Hospital, Devi Shetty's case. What he's done is assemble a whole series of elements, almost none of which were original. All of them exist either somewhere else in a health system or in a company like Toyota on measurement or peer circles, etc. And he's simply brought them together. He's assembled them into a package which then has a degree of clarity, consistency, and works because the elements complement each other. One of my concerns about health innovation is we test things as discrete units, discrete interventions. That has always been the norm of obviously medical testing and so on. Some good reasons for that. But my guess is that when you're looking at changing whole systems, and in particular reducing things like hospital admissions and readmissions, in fact, most of the gains will come from assemblages of a number of different elements. which will then reinforce each other. And most of those elements, when done individually, won't have worked very well, just as most of the elements of the iPod didn't work very well when they were separate. But then the question is, who has the power or the will or the money to do that assemblage on like a whole system redesign, not like the whole system demonstrators, but genuine whole system redesign for cutting hospital readmissions. That's what interests me. I don't see that happening. If anyone is doing that, we would love to work with you on making it happen. But my guess is if we simply continue with discrete experiments, we will continue getting discretely disappointing results.
Thank you, Geoff.